or perichondrium, or crushed cartilage, or diced cartilage. I will show you how to use the crushed cartilage to camouflage this tip. I have a special technique that I use. The first thing, get them at the same level exactly. So now the domes are mostly at the same level. And then, after supporting the midline and getting them at the same level, you can add your camouflage layer. And for that, I will take a piece of septal cartilage, I will bevel the upper edge, and then I will start crushing. And as you see, I leave a piece of the cartilage non-crushed, totally non-crushed, solid cartilage. And then I will take it a little bit outward, because I want it to be fully crushed in the upper part, but semi-crushed in the middle part, and non-crushed in the lower part. So it's a graduated thing. So the lower part is non-crushed, the middle part is semi-crushed, the upper part is fully crushed. That's the way I prepare it, and then I fix it by sutures, because the lower part, which is the stem of the graft, is totally solid. You can easily suture it. But you can't suture the rest of the graft. The rest of the graft, as you see, is very flexible, and it will totally cover the domes and camouflage any irregularity under it. So you can pull it in and put the skin back and suture everything. It gives a wonderful infratip lobule contour, and that's where the graft stops, above the domes, right there. So that's the way I use the crushed cartilage to camouflage these irregularities. She came from Germany with this bossa that kept recurring twice. And that's after I did her the same technique with camouflage. And the patient has to understand that the tip will get wider, but a wider and stronger and more stable tip is much better than a narrower and tip which is deformed. If she doesn't accept that, I won't operate on her. Again, all kinds of bossa before and after equalizing. Now, the infratip lobule redundancy is another deformity that can ruin any rhinoplasty, where the whole infratip lobule sags down. It's different than the hanging columella. It's the infratip lobule. The intermediate crura are hanging down. If you have a septum, then it is easy to suspend everything through a tongue and groove technique. And they come complaining of this V-shaped hanging part. It gets on their nerves, really. The whole infratip lobule fell down. Here it is suspended to the caudal septum. And immediately, this hanging infratip lobule will get improved. Again, 3 surgeries and the infratip lobule is hanging. Here it is flat. And the V-shaped hanging part will get improved. This is my own revision. I thought I improved her, and this part was hanging down. And she came with the same deformity. So I had to take her back and improve this hanging part by suspending it back to the caudal septum. And that will immediately improve this V-shaped hanging deformity. Now, anything you do to correct the infratip lobule deformity, don't excise the cartilage. She came to me with the same deformity, and she wanted this part improved. She couldn't afford to have her surgery with me. She went and had it somewhere else, and he did exactly what she wanted. He removed that part, and that's how she came back with a more ugly deformity, because everything will retract. You can see everything will retract. So I had to take her back and correct this deformity using an extension graft and the thick tip graft to bring down this minimal convexity of the infratip lobule, because that looks natural. Again, this guy had no infratip lobule. It was resected in the previous surgery. He grew a beard, he stayed at home, he quitted college for a whole year. It's a disaster for the whole family. So here, after giving him back a little bit of infratip lobule to look natural. Now, over resection may cause as well alar problems. Oh, this is not playing. This was in Germany, actually, in a course, and I was operating in a room and in Munich, and in the other OR, another professor was operating, and he said she wants a finer tip, and he took all this out through a closed approach. And he said, oh, she needs even a finer tip, and he took the rest of the lateral crus out. If you add them together, it's the whole lateral crus. And the head nurse there knows me because I operated in that course like 15 years. And she told me he's doing everything that should not be done. I said, yes, can you keep me the cartilage? So she kept me the cartilage till I finished my case to take a picture of how much resection was done through a lateral crus. Definitely everything will collapse, whether unilateral or bilateral. Once the patient comes to breathe, everything will collapse because there is no lateral crus supporting the lateral alar wall. In that case, you have to use the Gunter lateral crural struts. If you have septal cartilage, well and good. If you didn't, then go to ear cartilage. There is enough ear cartilage to support the alar collapse, and that's lateral crural grafting after 2 rhinoplasties. Again, lateral crural grafting on the right side. It will give a more symmetric nose, and even the concavities can change to convexities. The concavities post-operatively can change to convexities. If you look at most of the patients post-operatively from the basal view, you will find them concave in multiply operated cases. Alar notching is another sequelae of over-resection, and in that case you can put a drop of hyaluronic acid and it will improve the notching immediately. But again, even this one drop is not safe. I've seen disasters from it. Look, just trying to get the alar rim down with hyaluronic acid. Trying to get the alar rim down with hyaluronic acid. Especially in revision cases, because they have borderline vascularity and you're injecting under a lot of pressure. And it's easy to embolize and necrose. So it is much safer to bring it down using cartilage, whether alar rim grafts or composite grafts, which I use a lot these days, composite grafts. So these are alar rim grafts with a little tongue and groove to improve that, alar notching. Again, alar rim graft, it will change this V shape into a more flat. But when there is soft tissue loss and the notching is that scarred, the cartilage alone will not help. You need cartilage and skin. For that, I use composite grafts from the ears. So this is the patient. This is the area I took the composite graft from in this patient. And you can see the deformity is not really a big deformity, but it can bring down the alar rim that much. And it will support it. And I never promise the patient they will be symmetric or at the same level, but the difference will be less. That's the only thing I can promise the patient. This is another patient, I took the graft from another area, which is again very hidden, under the inferior crus of the antihelix. It doesn't leave a visible scar, and that's the patient post-operatively. The scar is hidden in the shadow of the antihelix, but that amount of improvement can be achieved. A cartilaginous rim graft can never give you that in these scarred patients. Again, a composite graft to improve this left side notching. The last thing is the droopy, depressed nasal tip. When the support of the tip is weak, the gravity will kick in and it will move the tip backwards and downwards to lose both projection and rotation. You can easily look at the revision case and see how the medial crura look, and you dig in and you find that the caudal septum is flimsy and not giving any support to the tip. So I replaced that with a caudal septum replacement graft, a huge piece of cartilage, not your regular columellar strut. And it will take the tip cartilages and suture it to the caudal septum replacement graft. As you see, it is not sutured to the rest of the septum. If it was sutured, it would be an extension graft. I still have membranous septum intervening between. And it will improve the patient that much. Better support, better projection, better rotation. Where am I going to get this cartilage from? You can get it from the septum if you're lucky. I want this this ventral part of the septum sitting on the crest. This is the piece I want because this is the thickest piece of cartilage in the septum. The center of the septum is a little thin. If you didn't find this piece, then I go for the ears, and you can get the ear with perichondrium on one side and then fold it on itself and throw in a few sutures to hold these double-layered sandwich graft together, and it will give you a beautiful straight piece because you're suturing them back to back. So there will be no concave or convex side. And then it will replace the whole missing caudal septum. Or you can go to the rib, and that's always my third option, not my second option. Or irradiated cartilage, which I stopped using for support. I use only on the dorsum irradiated cartilage, but never use solid implants in the lower third to give tip support. That's Medpor, and that's silicone. That's after 7 years, and that's after 3 years. They will all extrude. This guy came from Swiss, and he had a septal abscess following septal surgery, so the whole caudal septum was gone. But the remaining part of the septum was there. I put a caudal septum replacement graft, and that's him after 2 years with good support and good projection. It helps in Miss Peggy's nose. In multiply operated cases, you find that the tip is too rotated cephalically. That's what we call Miss Peggy's nose. And for these cases, the caudal septal extension graft or replacement graft can work to bring it a little down. Again, multiply operated, and you can see the amount of superior rotation. This one I used only ear cartilage. Again, a big sandwich ear cartilage from both ears can give you that amount of lengthening and better. Very short nose, operated twice. Ear cartilage again, and diced cartilage on the dorsum. Binder syndrome, the only problem, the caudal septum is underdeveloped, but the skin as well of the columella is very short. So you need to lengthen that skin by a VY advancement, and then I put a premaxillary augmentation and that used irradiated on her, and that's 3 years follow-up for a Binder syndrome. This will be my last case. This guy had a septal surgery where everything was taken out. So he lost the dorsal support and he lost the tip support, and he keeps playing with his tip all the time at work because it bops back. And that's after a strong caudal septal replacement graft. It is too rigid, he won't be able to play with it, but it would look much better with better support and better projection. So this was a quote from Winston Churchill. They asked him to give a speech. He stood up and said, never give up, and sat down. And it went down in Guinness Book of Records as the shortest speech ever given by a statesman. He said only 2 words. And I will change that to never lose your tip support, never ever lose your tip support, because that's where most of the complications come from. This is my fellowship that you were asking about. The next one will be the 16th. This is an old one because I had one in July and December, and they work with their own hands. My job is only to assist them. And these are previous fellows. That's a plastic surgeon from Bristol. That's an ENT consultant from London. He's a professor from Rome. He's an associate professor from Milan. She's from Germany. She's from France, Kuwait, and London. She's from Spain, Bulgaria, and Swiss. Thank you very much.
Thank you, sir, for a very nice presentation. Any questions?